Good evening, ladies and gentlemen. Thank you very much for joining us for the press conference about the response to the novel coronavirus disease. We are using the simultaneous interpretation, so please use channel 1 for English and channel 2. Channel 1 for Japanese and channel 2 for English. 今同時通訳を使っております。
This is the English channel, testing the English channel. Simultaneous interpreter is testing the English channel, channel 2.
Ms. Kamoshida Naoaki. I am the director for International Press Division of the Ministry of Foreign Affairs, and I'll today serve as a moderator for today's press conference. Today we have briefers from the Cabinet Secretariat, Ministry of Health, Labor and Welfare, and the Immigration Services Agency. Next to me is Mr. HOSHIDA Junya, Councilor from the Cabinet Secretariat, Coordination Office of Measures on Emerging Infectious Diseases, Office for Pandemic Influenza and New Infectious Diseases Preparedness and Response. And then we have from the Ministry of Health, Labor and Welfare, Mr. SAHARA Yasuyuki, Senior Assistant Minister for Global Health. Mr. TAGUCHI Kazuho, Director, Office of Global Health Corporation. And Mr. KATO Takuma, Director for the Measures on Novel Influenza Control Office. And from the Immigration Services Agency, here with us is Mr. UMEHARA Yoshihiro, Deputy Director of the Inspection Division. Today's press conference is given on the record. And I'll ask our colleagues from the Ministry of Health, Labor and Welfare to brief you about the current situation of the infection of coronavirus in Japan, and also the current status of PCR testing. And then I'll ask Mr. Hoshida from the Cabinet Secretariat to briefly explain about the special measures law and the response measures which were announced last week. Then I will open the floor for questions. And when you ask a question, please raise your hand and use the microphone and indicate your name and affiliation before asking a question. So, without further ado, I would like to invite Mr. Sahara to brief you about the current status. Mr. Sahara, please.
Good evening, ladies and gentlemen. My name is Sahara of the Ministry of Health, Labor and Welfare, and again, thank you very much for gathering here this evening. I will speak about the current status of infection and the spread of infection in Japan and the PCR test availability and performance. Handouts have been given, and the first page will be explained later. Please go to page 2. This is a table that describes the number of patients that have been hospitalized and discharged, domestic cases, cases at the cruise ship, and the breakdown have been indicated. For the domestic cases, 15th of March, these are the numbers as of March 15th. Those who tested positive in PCR totaled 809. So this is indicated as plus 32. That's on a daily basis, so the number increased by 32 in comparison to the previous day. Of them, 164 have already been discharged, and there are currently 621 patients currently being hospitalized. Those who have passed away count 24, and in comparison to the previous day, the number of deaths has increased by 2. And for the cruise ship, the total was 672. And of them, 458 have already been discharged, and those who are currently still hospitalized amount to 207, and 1 have died, or 7 have died. And then please turn to page 3. On the left-hand side, you will find a bar chart which describes the daily number of confirmed cases who had tested positive in PCR tests. In comparison to the past, the number has increased in recent days. It's been between 30 to 50, or for some days, the number has surpassed 50. But there is fluctuation day by day. March 14th, the graph goes up to March 14th, but March 15th was 32 and 16th was 15 confirmed cases according to latest reports. However, due to the time lag or delay in reporting, these numbers are not final numbers. There could be some upside. And then on the right-hand side, you see the number of positive cases on weekly basis. Obviously, the number of patients is increasing, and we will continue to vigilantly monitor the circumstances. Going on to the next page. This is the age distribution of those who tested positive. Those in the 50s and 60s are the peak age brackets, and then slightly down 70, 80, and the deaths have all been above 70. And now going on to page 5. This describes cases by prefecture amongst the 47 prefectures in Japan. There are several prefectures without any patients. On the other hand, there are prefectures like Hokkaido, Tokyo, Aichi, and Osaka, where the number of patients is high. On these cases, we are monitoring clusters. Localized transmissions have created clusters, and on the next page, you see the results of cluster analysis on page 6. These are the main clusters in Hokkaido. There are 2 clusters. Another example would be on the right-hand side, Chiba Prefecture. There's one in Chiba and another one in Tokyo. These clusters have emerged. Municipalities and the Ministry of Health, Labor and Welfare and experts are working together to conduct robust contact tracing. And we are trying to implement cluster control. On nationwide basis, these are the clusters that have emerged, and the key to end this outbreak is to respond to these clusters. Next page, page 7. Last week, the same page was shared with you to explain the procedure in Japan for PCR testing in Japan. This is the fundamental flow chart. Patients who are worried would consult the call center for Japanese returnees and potential contacts. And at the outpatient facilities for Japanese returnees and potential contacts, or the call center will refer the caller to the closest outpatient facility, and the potential patient will go to the closest outpatient facility in the neighborhood. This is the system that has been established to prevent the potential cases or potential patients going to ordinary clinics. And that is why we have established this kind of system. And depending on the clinics, doctors can deliver professional judgment on whether PCR tests ought to be performed or not. Last week, on the 6th of March, since Friday, 6th of March, the tests that are conducted at these outpatient facilities have come to be covered under the health insurance system. So without out-of-the-pocket money, potential patients can receive tests through insurance coverage. Going on to page 8. The red shaded section is the nationwide test capacity for PCR assay in Japan. The capacity has been gradually increasing since February, and at the moment, 7,000 tests can be performed at the moment. And the blue line indicates the actual number of tests performed last week, which was after the public health insurance coverage. Per day, between 1,400 to 1,600 tests have been performed on nationwide basis after the test was included under public health insurance coverage. The NIID, or the quarantine station, had been performing the PCR, but local public health institutes and private sector laboratories have also entered, and universities have also joined the camp of test performance, and that's the reason why the number of tests performed has been increasing. So that concludes my overall explanation, and I would be happy to respond to your questions later. Now, finally, going back to the cover sheet. This describes the fundamental concept of the government of Japan. What's important is to control the situation with spreading infection, and one key is to delay the arrival of the peak, and the height of the peak must be lowered. So these are the keys. At medical institutes, many people will have to be hospitalized if there is a sudden surge, but we want to mitigate the flow of potential patients being hospitalized. And please focus on the upper direction arrow. By delaying the peak, we can buy time, and during that time gained, the response capability and capacity at hospitals and medical institutions can be gained and increased. For example, number of beds at hospitals increasing, or having teams that can respond to infectious disease being established, and making the hospitals better prepared to respond to novel coronavirus. Of course, we will continue to watch the spread of infection. We cannot predict, but if the number of patients can be well controlled and there is no significant increase, then that's fine.
And it is possible that the number of patients will increase in the future. So we have to be prepared for various scenarios. However, this is a fundamental, a basic concept in responding to new coronavirus measures. So that's all from the MHLW for the time being.
Now I'd like to invite Mr. Hoshida to explain briefly about the special measures law and emergency response measures.
Thank you very much, and thank you for this opportunity. I'm going to explain two things, but in Japanese, actually.
The first thing I would like to explain is about the revision of the law. The special measures law for pandemic influenza. This law has been revised by introducing new coronavirus under the coverage of the law. This special measures law covers new influenza like the one, Spanish influenza in 1918, and also new influenza which spread in 2009. And new coronavirus. Infectious diseases were not covered by this law. However, we made the revision to this law in order to cover coronavirus. On the 10th of March, it was decided by the cabinet and submitted to the Diet, and it was implemented on the 13th of March and became effective on the 14th. As a result, new coronavirus now has a legal foundation so that we can implement even more stronger or the aggressive measures. Under the certain conditions being met, we can issue a state of emergency based on the law. So that is the first point. The second point, on the 10th of March, we announced the emergency response measures. In order to prevent the spread of infectious diseases and also in order to respond to various challenges, in order to respond effectively to the situation, government issued the new package. The size is as follows: 400 billion yen of fiscal measures and also 1.6 trillion yen of monetary measures are included under the package. There are mainly 4 pillars under the package. First pillar is the measures to prevent the spread of the infectious diseases and to provide medical services. As was discussed earlier, in order to respond to clusters, MHLW dispatch experts to local governments, and also the face masks are in shortage now. So they are all sold out at pharmacies. Therefore, we prohibit resale of face masks. And also, the national government bought 20 million masks to distribute in emergency manner to the nursing care homes. As was mentioned briefly earlier, PCR testing has been strengthened. So that is what is included under the first pillar to prevent the spread of infections. Second is related to the school closures. School closures, as Prime Minister Abe requested, is now in place. As a result of school closures, the children who are going to schools, their parents, for example, their parents have to take a leave from their workplaces, or when they have to work, their children are used to go to after-school facilities to be taken care of. So these children are now able to participate in after-school facilities even from the morning period. So as a result, the government is going to provide a financial assistance to cover additional cost increase because of the opening of after-school facilities. The third pillar is to respond to employment and the shrinkage of business activities. New coronavirus infectious diseases are expanding. As a result, economy is facing difficulty. There are many businesses which are in dire situation. To respond to such a situation, for example, in spite of the difficult situation, some companies do not fire employees. Under the certain circumstances, the government is ready to provide assistance and also to help funding difficulty. We have a special lending scheme that the companies can use. The fourth pillar is emergency measures in order to immediately respond to changing situations. As I said, we have a new law. Also, border control, border measures will be implemented in a swift and flexible manner. So these measures have been announced. So these are the second stage of the emergency response package. That's all. Thank you very much.
So now I'd like to open the floor for questions, but please raise your hand and indicate your name and affiliation. And because we are using the simultaneous interpretation, please use the microphone. Then Mr. Parry.
Thank you. Richard Lloyd Parry of The Times. My first question is about testing, and particularly about this graph. So this shows that your capacity for testing has increased quite a lot, but the number of tests carried out hasn't really increased very much at all. Why is that? Why, given you have this capacity, why not use it to conduct more comprehensive and aggressive program of testing, given that the example of, for example, South Korea suggests that that can be quite beneficial? That was the first question. The second is, as you know, there is a suspicion that's been voiced by some people that the number of cases in Japan is higher than the published figures, and that the reason we don't know this is because you're not carrying out more testing. In other words, there's a hidden number of coronavirus cases that you don't know about. Now, if that was the case, one assumes that it would show itself nonetheless in admissions in hospitals for pneumonia. So I was wondering if you can tell me, separate from all the figures you have about coronavirus, what are the figures this year for treatment of pneumonia in Japanese hospitals? And how many of those cases are there, and how does their number relate to the annual average? Thanks.
Thank you for the questions. With regard to testing, to what kind of people are we providing tests currently? To that question, I think there has been an evolution so far. At the risk of being repetitive, I would like to say that in February, in the beginning of the February, or from the end of January, from China, there have been Japanese returnees from China, and also those who are close contacts to these people. So our policy was to test these kinds of people. For one thing, because of the testing capacity was limited back then, and at that stage, we were not able to provide testing, or we didn't find it necessary to provide testing to everybody. And then testing criteria and also the people to be covered under the testing, gradually we expanded the scope of targets. From the 27th of February, each and individual doctor can make a decision whether or not to perform PCR testing. That is how we are operating the system currently. At the end of February, even at that time, as was pointed out, in performing PCR testing with public health centers, the consultation needs to be done. That was a condition imposed. That is because the testing was done as part of epidemiological investigation. That was the history related to such a system. Therefore, this is the scheme we employed back then. On that point, we have made a revision to that 6th of March from Friday. For this testing, public health centers consultation is no longer required. So completely each doctor at each hospital can take a decision whether or not to perform PCR testing. And also the testing to be performed in that way are covered by national health insurance system. So insurance coverage is now provided. Those who do not have money are actually able to be tested by this system. Now, why the actual number of testing is short of the capacity that we have? Well, just because we have capacity, it doesn't mean that we need to use that capacity fully. That is not the case. Also, just because people are simply worried, for such a people, it doesn't necessary to carry out tests on these people who are just simply worried. At this point in time, doctors observe symptoms, and if infection is suspected, doctors can decide to perform PCR testing so that treatment can be started as soon as possible. Also, the second question. Those who are hospitalized may include the patients who are not detected as a coronavirus patients, and the infection may be spreading as a result. That was your question, I think. Compared to the last year, at this point in time, we are not able to provide the numbers in comparison to the last year's track record. And currently, now the national health insurance is applied. Therefore, if doctor decides that testing is needed, of course, tests can be performed. And if a patient unfortunately dies and there is a high level of suspicion about the infection, for such cases, PCR tests are performed, and we have requested each medical facility to carry out PCR testing after the death of such patients. At the risk of being repetitive, regarding PCR tests, it isn't that we are performing PCR tests for those who would like to be tested. Rather, we should test those who require testing. You cite example of South Korea, but we are not in position to comment on the South Korean situation. If there is a big clusters like South Korea, I think there is a need for testing a huge number of patients. Of course, we have to assume that there could be large clusters in Japan going forward. That is why we secure capacity for PCR testing, and we are going to increase PCR testing capacity even further going forward. Now, the number of pneumonia cases as Mr. Sahara said, in terms of quantitative numbers, we don't have the data now. However, as you pointed out, suppose if we have a mass infection of a severe pneumonia, then in that case, we can detect the situation in regional medical facilities, and also local health centers make a report to us. So far, because of the mass infection of pneumonia, there has been an overshooting of system. No, that has not happened so far yet. The pneumonia without known causes but require hospitalization, under the MHLW, we give a priority to such cases in PCR test performance. For pneumonia patients who are hospitalized without known cause, we can immediately perform PCR testing now.
Just clarify on that last point. So, as I understand it, you're saying that you would be able to tell if there was a surge in pneumonia, but you're also saying you don't have any figures and you can't say what the situation is this year compared to previous years. That seems to be a contradiction. How do you know whether there's been a spike or not if you haven't got any figures?
First of all, the reason we do not have figures is because, unfortunately, because of the statistics procedure, it's not designed in Japan as such. For a specific disease, timely capturing the number of hospitalized patients is not covered in the statistics system. That's why I say we do not have the specific numbers. But in a certain locality, if there's a surge of patients, the hospitals make adjustments with regards to hospitalized inpatients, and there could be inpatients surpassing the bed capacity of those local hospitals, which is captured by the MHLW. That's why we say we know the surge. And if there are certain group clusters or collective infection being caused, we have told municipalities to report such cases to the ministry. If I may add to that, page 5, if you could take a look at page 5, by prefecture, the situation is plotted in the diagram. And taking a look at this diagram, there are prefectures with high number of cases and fewer number of cases, and prefectures with high number of cases would be receiving experts and staff from the Ministry of Health, Labor and Welfare. And in those areas, we capture the utilization rate of hospitalized beds. This is not precise statistics, but on daily basis, the ministry communicates well with these municipalities. Right. Clusters are also reported by the municipalities. That's why we are capturing these clusters. And we are aware that hospitals in those clusters are being utilized. So constantly we are vigilantly monitoring the situation in those localities where there are clusters. Thank you.
To follow on the question of testing. I have read some articles that suggest that Japan has a strategy of not testing as much as other countries, in part not to panic the public and not to have people flood the hospitals. Is that your explicit policy? That's one question. And then the other question is, if it's true that you're not seeing a particular surge of non-classified pneumonia cases and Japan is somehow managing the outbreak, How exactly are you doing that? There was a report out yesterday from Imperial College that seems to have motivated the American government to urge a much more severe lockdown than we're seeing in Japan in order to, so that, as they put it, flatten the curve. Why are you not doing that in Japan, and can you explain why Japan has not had a more severe outbreak?
On your first point, are we doing this in order to prevent panic? We are not implementing any policy to hide anything. That's not in our agenda. I've described our strategy in performance of the test, and we will continue to follow that strategy. And according to our understanding, in fact, this kind of policy is being applied by several countries. They are prioritizing patients with symptoms and performing tests, prioritizing those people. So we do not believe that Japan specifically is taking a unique and different policy in comparison to other countries. And then what's proven to be effective? Why is it the case that we've been able to control the outbreak or spread of infection? At this stage, it's extremely difficult to assess the reason why. And on this point, experts of the infection of novel coronavirus have formed a panel, and I shared with you their views at the previous briefing, but at the experts panel, they are doing assessment, and we have to wait for their conclusion. And we, on the part of the ministry, consider that it's important to wait until they come up with a conclusion. In late February, they came up with the opinion that the next week or two for Japan would be the extremely critical timing. And that recommendation was submitted by